crown on the lateral incisor. And this is what I did. I did the crown lengthening, internal bleaching. I placed my first zirconia abutment on top of Granemark implant, and I did use two Procera crowns. Okay. Highly blind, we did some crown lengthenings on the side. And when I finished her, she was 25 years old, and this was in 2002. She had the Serra 1. I used the titanium abutment with an alumina crown. And 1 year and a half later, she calls me and she says, Iñaki, I have a problem. My implant has a problem, and I don't know what's going on, but I have a huge inflammation. Can you see me? Of course, I saw her, and what you can see here is cement here, cement here, cement here, cement here. At that time, in 2002, I didn't have any protocol for cementation of my crowns. Okay? At that time, we didn't have screws like Omnium grip to compensate our angulations. So basically, she's now 38 years old. This is my crowns. I cleaned the side, and this is how she looks like 13 years later. This is my work. Okay. So she came and she said, Iñaki, I'm not 100 anymore. I don't like my aesthetics. My teeth are growing, and they still are longer again. Can you do something? I say, yeah, I'm trying now, and we'll have to cut the crown. You have a big problem because you have lost also papilla, of course, local recession. So we need to do some grafts, at least one or maybe two grafts on those implants to bring back the scallop. So I cut the crown 13 years later, and then I was ready with my camera to see what was happening here. I placed a provisional restoration with some pink, and she said, it's beautiful, can you leave it there or no? Just didn't start yet. To tell you the truth, I think this piece of cement was stuck on the soft tissue and collapsed when I took it off, but you can see all the amount of bacteria we have in an external hex in something that we were supposed to have a perfect fit. Okay. So it's impressive to see this. And what I did is I did 1 round of connective tissue graft. And we'll discuss tomorrow morning that the more you keep the abutment in place, the more you are limited on the amount of tissue graft you can graft crystally around the implant. So this is 4 months later. Usually when I use only connective tissue graft, I re-intervene after 4 months. At 2.5, I check and I see my papilla height, the papilla is leveled, the connective tissue of the buccal is not leveled. So I did a second connective tissue graft, and I graft interproximally and buccally. The idea in prosthetics, the idea in periosurgery, is that you always want to have the scallop of your pontic or your implant be coronal to the one you want to copy. In this way, you will always push the tissue and have a perfect scalloping of your crowns. Okay? So you can see after the second round, You can see here that the papilla is a bit higher than this one, but pretty much everything is under a situation where I can improve the final result. Okay? It's very much where I want it. I want to check if this papilla, if this tooth has a contact point. Every time I place an implant, I always take floss and check all the interproximal contacts among the rest of the teeth. If you have a diastema here, the tooth will move distantly. So I always check interproximal contacts between the teeth to avoid the migration of the teeth. Okay? So we are under an ideal situation to push the tissue and create something that looks nice. Now I had the chance to bleach internally the tooth because it became dark, and I placed the provisional restoration. And I don't know how you control the contact points between your teeth and the implants. If you use an articulating paper, you have a problem, because you will always leave the thickness of the articulating paper you have used. We always control the contact point between an implant or between implants or between an implant and a tooth with filter. So we paint, we dry, we paint. You know that there is a certain steps. First, we control the contact point, and once you have a good contact point, then we check for the adaptation of the crown. So interproximal contact points are really important. So to check. Usually, if you look at my book, 90% of my teeth adjacent to the implant has a composite. Why? Because I want a contact point that is as wide as possible vertically and horizontally. It goes from the tip of the papilla to the gingival embrasure and buccolingually as wide as possible. Okay. So you can see that I paint, I place it back. If it touches, you will see the white spot with a really thin grit, red band grit of diamond. I will cut this whitish spot until I'm done and I see all black. That means that I still have a contact and I will have a floss and a good contact point. Okay? If you use articulating paper, you will always end up with the space of the articulating paper. So we always control the contacts with black filter. Especially when you screw in a crown, the pressure you create, if you have too strong of a contact, you can move all the teeth laterally. The patient is going to tell me, it's hurting all the way back to the first molar. Okay? So you need to be careful, you need to be patient, you need to control the contact points between your implant and the rest of the teeth. Okay? So every time you use final zirconia abutment as a provisional, always remove it and check if there is no cement excess around. And now I always use two totally independent cords. The cord that we use, the diameter is based on the mobility of the flap, how thick is the tissue. The cord should be just in front of your finishing line of the prep. And the cord is there just to avoid the cement to flow apically. You need to teach your assistant how much cement you have to put inside the crown. The cement inside the crown is placed with a brush and is painted. All the surface of the internal crown is painted. We never fill the crown all the way up with cement. It's way too much. Okay. And then why 2 cords? It's always packed into the adjacent tooth. So once I place the crown, I can remove totally independently the buccal versus the palatal cord. I remove the buccal, but the palatal stays in there, so I can blow with air to see if there is no cement left on the socket. This is what it looks like. I always go sideways on the adjacent tooth so I can remove the cord in an easy way. So if you stay within the implant, it's impossible to go and capture it. Okay? She's coming back 1 week after, this is where we started. She came with her daughter, next patient. And this is what it looks like 1 year afterwards. Okay? You can see the teeth are splitted to avoid migration as much as possible. But which is the reality in 2020? Well, she came because she fractured a little bit the incisal edge. But you can see that even though we split it, the tooth migrated a little bit. Okay. So I would like to ask you, how do you solve an adjacent tooth continuous eruption? Do you have that in Vietnam? Of course. When was the last time you had to fix an interproximal contact next to an implant? Do you have that problem? Yes, I do. How do you manage the tooth restoration between 2 implants? Okay. I would like to discuss a few cases. This is another one. This is how she started, a bridge, an implant that was buried, an implant, natural tooth, 2 implants. We placed 3-unit bridge. 3 years down the road, single crown, extrusion. This is the bridge. This is how we started. This is what we did. We brought 8 millimeters down the papilla, only with soft tissue. This is 7 years. Class 2. So which are the basic criteria for predictable success? Which are the expectations, the limitations? Do we always need a connective tissue graft? Well, for me, I always do a connective tissue graft. This is what saves my problems in an easy way. Why we need connective tissue graft? Well, until we don't make a prosthetic abutment where the fibers will connect to the prosthetics in a particular way, we are in a certain way condemned to do connective tissue grafts. Maybe in 100 years they will say, this Gaborena guy was crazy. He was doing connective tissue grafts around implants. But today we don't have too many ways to solve this problem. So here is the problem. You can see, thanks God, she has a lot of soft tissue. So we need to bring 9 millimeters this tissue down here. Is it possible? Well, it depends your dexterity. depends your knowledge, and it depends, of course, if the patient has sufficient soft tissue to really graft crystal. On her, she had 9 millimeters of tuberosity in this side, 9 millimeters of tuberosity in this side. So now it's a matter of being able to place 9 millimeters crystalline, which is not easy. Okay? So if you look at the bridge, this is the situation. You can see we have a frenum. Everything is mucosa. You can see the vertical releasing incision. Just here, the implant that is buried. And for me, frenum is not my enemy, it's my ally. I almost never do upper frenectomies. Okay? You will see why. So you can see here, the red is the angulation of the implant, the blue is the angulation of the prosthesis, which is on the limit. And I will discuss that in more in depth, which one can be performed, which one will have to extract the implant. So this is the scenario. This is the first connective tissue graft, the first round of tuberosity connective tissue graft. This is how much I was able to improve the vocally. The frenum was not removed. This is 4 months after the first surgery. This is the second surgery. This is 2 weeks after the second surgery. We place an immediate implant placement on canine to do a bridge with a pontic and a single crown central incisor. You can see this abutment is the same that the patient is wearing. We remove every single and make it as narrow as possible. This was a Paragon implant. I didn't have a healing abutment, but usually what I do is I remove as much horizontal component as possible of my abutment. I just leave the hex just to really be able to graft as much as possible where I need the best, which is cresta. This is all soft tissue. So I have to go above the mucogingival line. I have to be above the fornix. The fornix is where the total soft tissue becomes the lip. So I have to go at least 3 millimeters into the lip to bring that soft tissue down. And now you have to recognize the difficulty. Which is more difficult? Shallow vestibule or high vestibule? The high vestibule. Why? Because with the high vestibule I have to go really high to really bring everything down. Okay? The shallower the vestibule, the easier it is to bring the tissue down. The higher the vestibule, the more possibilities to perforate the flap. Okay? The more the teeth are protruded, the more it's difficult to do the tunnel. Okay? So there are the position of the maxilla, the length of the maxilla, the premaxilla is going to limit how much you will be able to advance your flap. Okay? So those are limitations inherent of the patient you are treating. So here we want to, the thinner the tissue, the more I do full thickness flap. Because I want to elevate the thickest flap possible so it doesn't terror me. And then I don't use spatulas for cutting. I only use spatulas to stretch, to elevate, to create pressure, on a tissue that has been already cutted and able to mobilize in a better way, or to control that my tunnel is perfectly tunneled, that I don't have any pieces of or remnants of tissues that doesn't allow me to glide my soft tissue. And you can see here that my flap, my tunnel is going to allocate my soft tissue, but I want to perfectly, I forget about the implant. I take out, you will see on videos tomorrow morning, how we deal with recession around implants. At that time, I didn't have videos, and I totally forget that it's an implant. It's like a ridge. And what I do is I first come from the outside in. See, outside in, I go into my flap. I'm going to insert my connective tissue through the medial aspect of my canine into the tunnel. And then it's going to be sutured by 4 extremes in order to place it exactly where I want it vertically. Okay? And then I will make a hole. You will see it in videos. I will make a hole, and I place my abutment in order to deliver my provisional that is not creating pressure on top of that tissue. Okay? So this is the second round of connective tissue. This is the result 15 days later. I place an implant. I want to bring more tissue distal. And this is how it looks like 15 days later after my second round of connective tissue graft. I place an immediate implant placement and plug it out vertically. Okay? And then I place a new provisional to boost the tissue. I use PMMA provisional restoration. Usually those provisionals are too beautiful, so the patient sometimes delays a little bit the final result, which is a pity and a problem. If you can see, that papilla has been raised 9 millimeters vertically. So this is where we started. In none of the situations we have grafted, so the tissue on top of it keratinized, and we kept, of course, the implant just to bring the tissue to a different height. We look at number 13. You see, we left the cover screw and the angulation. I use gold abutment to compensate the angulation and able to restore this implant. This is where we started. This is how I finished. So basically what we're going to see is how to reconstruct the volume and compensate the volume loss only with connective tissue. I'm not going to talk about bone, but really, sorry. This is the video recall of the patient. She's coming from south of Spain. It's about 8 hours drive to see me. It's difficult always to find people to come back and do a checkup. It's about 3 years down the road, and the situation. Okay. This is 7 years later. You can see how the tooth is growing because it has never been splinted. Even though this tooth has a contact, this can become a problem. So far, she is not concerned, but one day she will come back. So I would like to talk about connective tissue grafts, the donor side, the surgical techniques, the harvesting management, the benefits, the complication, and the management. Okay? And the first question is, does pseudoepithelial connective tissue graft matters? Absolutely, it does. For me, there are the first paper from the Ritchie group, which were showing what I was seeing clinically, which is that in tuberosity, the tissue always tends to grow, and it's something that you should be aware of. If you graft from 3 to 5 millimeters in thickness, that tissue can grow in excess in some people. One of the tips I can give you is that if you find a patient that has lingual thorax bone, and you're gonna grab tissue from this person, you probably have hypertrophic reaction of the soft tissue, because that tissue tends to grow more than normal. Okay? This is related to bruxers and the thicker final dies. Okay? So is a tip that we use. Okay? For me, there are 3 areas. If I use teeth, I use Zucchelli technique. I take the hard palate. And I take what is called the lamina propria, which is the thicker and denser soft tissue, just below the epithelium. I only take the 1.2, 1.5 millimeter thickness of soft tissue. Okay? This tissue is the densest connective tissue you are looking for. Okay? Compare the tuberosity, same stains, or the retromolar pad. The retromolar pad is where the dentures should be lying onto. Okay? Sometimes you have enough for 2 premolars if you have an extension, or 1 lateral, or even a central incisor. And tuberosity usually is used for, I use it for implants, for defects, when I want the tissue to grow. In pontics, many areas that we can use this tissue. What is the difference between them? Is the collagen type. This collagen is type 1, and it has a continuous growth. It doesn't have vessels. You can see here the vessels. It doesn't have adipose tissue. So this problem, this tissue is a tissue that cannot be exposed to the oral cavity, because if it's exposed, it necroses. And I will show you what I mean by that. Okay? So I have 3 areas: tuberosity, retromolar pad, superficial hard palate. The best superficial hard palate is not in front of the first molar, is behind the first molar. This is the most glandular soft tissue you can find. This tissue looks like it's nothing, but usually is trapezoidal. It goes from the lingual oblique line to the buccal oblique line. You have little amount of gingiva. It depends if the patient had wisdom teeth extracted or not. You can find a lot of tissue in here. So I always touch it and have an idea how much I have in there. Okay? So we are all the time exploring different areas. I know so many periodontists that always use this part for everything. No? We use a specific tissue for a specific problem. We are not like a restaurant, a menu for everybody. No, we are a restaurant a la carte. Okay? You have this problem, I'll give you this tissue. Okay? So let me show you where I use tuberosity between teeth. I use it when I have interproximal defect. Let me show you where I use, for instance, retromolar among teeth also. Why not? And let me show you where I like to use Zucchelli technique, thin tissue around the natural teeth. Okay? So I will share with you different situations with different soft tissues. Okay? So the first one is, well, this guy is a class 4 Miller or 3, I don't remember now. There is no palatal soft tissue. It's a challenge. It's a cardiac surgeon. He's coming from France to see me. And I told him, well, it's gonna take me a lot of effort to really be able to fill this gap. And this is how we finish. This is Patrick Rutten, one of my technicians I used to work with. And this is a group of Japanese people. And I choose him as a patient. I place an implant on the lateral incisor. And he told me, why not? So the Japanese dentist came to see how I did connective tissue and immediate implant placement on the lateral incisor. And he told me, why don't you change both central incisors? And I said, well, no. Those central incisors were done by Eric Van Duren, a really good dentist. And I say, the crowns are perfectly fitted. Let's do just a connective tissue graft from the retromolar part because you have enough tissue for me to graft it. And this is the final result. And usually when I have a really dark tooth, if you add connective tissue on the buccal aspect, you will create a dissimilarity on the emergence profile. So what we do is I cut the root in order to have the same emergence profile with my soft tissue compared to the contralateral tissue. And this is how we do it. We reduce the diameter of the root of the patient. We do a class 5, of course, without touching the bone. And then we take a connective tissue from the palate. We thin it out just 1 millimeter so it doesn't overcome and make it too bulky, to donut effect. And this is the final result. Okay? So let's look at how we take the connective tissue from the tuberosity. Usually this is the green part. We do a simple wedge technique, nothing new. But we take all of it. Why we do a wedge? This wedge is about 1.5 millimeter incision. And we de-epithelialize sideways about 1.5 millimeter in thickness. The thinner the tissue, the more in necrosis, the more pain for the patient. We want to have the incision at least 3 millimeter apart. So once we take all the volume inside, we just suture in one line. The bigger quantity of soft tissue in the tuberosity is on the crest and on the palatal aspect, not on the buccal. Okay. So what we do is we make incisions to remove all the soft tissue, and I will show you in a minute a video about how we do it. The idea is to calculate which are the distance of both incisions to end up with a line on a totally different level and cover the bone so it's not denuded, okay? So it's not painful for the patient. So this is the video. So we do, it's on a model of a dinosaur as a patient who will be able to have a nice video. This wedge gets together at the end of the angular notch, which is the part here in the back, which is mucosa. And then you elevate 1.5 millimeter thick tissue following the anatomy of the palate. Usually this is about 1 millimeter thick, so you take your instruments as a guidance. You have the posterior nerve here. Usually we never bypass the length of your 15 blade, which is about 9 millimeters. And you open the soft tissue, partial thickness, okay? So the tissue is still bonded to the tooth. Never bypass the 9 millimeters of your blade. The flatter the palate, the closer the nerve. You can really look at on the crest. We make an incision. Usually I change it. I always cut to the bone on the buccal. Then I elevate. I see the amount of tissue I need. And then I go forward, maybe sometimes up to the first molar, based on the amount of soft tissue I need. So then we rest on top of the tooth and we detach it from the bone and you cut it at the base. And this is the amount of soft tissue. This is Angus beef, okay? The palate is McDonald's. Okay? So, and then we suture in one line. The needle should go once, and we don't go one and then the other one. What we want is to have a precision on the adaptation of your flaps. So we go once. All my needles are long needles, 17 to 19 millimeter long needles. And just to control, I level my flap and then I go across. Okay? And you finish. Okay? So this is the greater palatine artery, the distances, and there is a fantastic relationship of your greater palatal artery related to the anatomy of your void, of your maxillary anatomy, and there are great studies showing you the distances. But what I would like to show you is the study we did. Does the harvesting technique matter? This is something that I would like to share with you. We have done cases, and this is, for example, done by a student. Okay? And what we did was we removed the soft tissue from the palate. And as you all know, what we want is to get rid of the epithelium. You can see here, we did a histology. And what we did on the study was we took a dentist from Gaborena, and they took the piece of tissue and they de-epithelialized outside the mouth, and the other group de-epithelialized inside the mouth. And then we look at the microscope and check if the guys that did it better
taking the tissue outside, or is it better taking the tissue inside? And we look at the microscope to check which one was better. Okay? So why is it important to de-epithelialize our connective tissue grafts? Well, because if you don't de-epithelialize correctly, you will have micro pouches. The tissue will never adhere. You will have like voids within the tissue. And those voids will come up to the surface, okay? And then you will have a problem. This is something that was done, only 2 papers that I know of. I was involved with this paper with histological evaluation, which is much better done than the previous one. So you can see that even when you take the soft tissue from the tuberosity, there is one place that many people forget, which is the sulcus. The sulcus of the second molar, which need to be removed. Not only the epithelium on the crest, but also the epithelium from the sulcus. And these are little details that make the difference. Okay? So if you don't take it, there is a lot of articles showing that you can have problems. And more we are doing connective tissue grafts, and this is something that you should be aware of. That depending upon the technique and how you do it, you can create problems. So let me show you one case of mine. Let me show you one problem I got. And let me show you what happened. So this is a patient come to me like many years ago. Has a fistula here. Has diastemas. The fistula is coming from number 11. This is number 11 versus number 21. What would you do? I always start from the most difficult one, which is 21 or 11. Who says 11? Raise your hand. Come on, it's just a game. How many of you will place an implant on number 21? Which one will you start with? Okay, so let me show you. First I did some composites, because the guy is the same day composite, like 3-hour composite, just one dentin and one enamel, has the same clothing, okay? He's happy. I'm not, it was a difficult case. So I polished everything. And the first thing I'm going to do is I'm going to extract number 21, which is the most difficult because it goes all the way up to the nose. So I place a membrane in the base of the nose and I fill it. This is the day 0. I fill it with xenograft material. And then I did an incision on the apex to get into the root, grafted with a membrane and tags. Use EDTA to seal as much as possible the root. So I'm going to do one implant at a time. I'm going to wait 8 months before I go ahead and place my implant. You can see the resorption that happened. And once I have, once I have done my implant, please notice that I have bone resorption vertically of 2 millimeters. And this is something that I would like to address that I always, depth is crucial on grafted sites. I never place the implant level to the bone. I always deepen my implant at least 2 millimeters, because I know that 2 millimeters, that bone will resorb, and I will still want my implant to be buried into the bone. This is something that we learn the hard way. Okay? And then the idea is to place an immediate implant placement in here. I did first the delayed implant, and then once I have done the delayed, I see I need a second connective tissue graft here. I did a second connective tissue graft, and then place my implant. This is how it looks like 6 months down the road. You can see I still have bone loss. I finish my case. This is where I started. This is where I finish. Okay? Have some bone loss on the central incisor. So the patient asked me, hey, I love it. It's 2011. This is 2011. This is 2018. This is 2021. What do you see? The diastema. So I always, and what do you see? He was asking me, hey, I have a little amount of paste from endodontics here. So what I did is I deepithelialized with the burr, and then all the micro fistulas came out from the tissue underneath. So I opened the problems. Why is that? Because my tissue was not well deepithelialized. And this is difficult to solve. Actually, you never solve it. Okay? And I would like to share my problems too. You can see I use many times laser. I even cut the surface, making it rough. So in this case, this is a video. Please, I took my crowns off. These are the abutments I used at that time. And what I'm going to do is I'm trying to get rid of these micro pouches. Okay? Please pay attention what I mean by that. Okay? You can see this is the view on number 21. And I squeeze with my finger the buccal soft tissue. And please notice everything that comes from the soft tissue. This is micro pouches. I never deepithelialized, so you will have bacteria in between because of the poor removal of your soft tissue. Okay? So we use laser to deepithelialize, but it's really difficult. You can improve it, no question about it. And what I did is I deepithelialized, I did a peeling. You know that the epithelium grows really fast. I go into all the little fistulas and try to deepithelialize, but I don't have a microscope in my eyes. So basically I'm working blind, okay? And I'm trying to cut the soft tissue and then trying to rebond, reattach this fistula. You can see how many. And this is because the soft tissue was not deepithelialized correctly. So you can see the problems this deepithelialization can cause. Okay? So we sutured it, we go all over, so we increase the speed of new soft tissue, which helps on the overall turnover of the soft tissue. And you see, we are going to suture now. All those holes, we try to, this is a short version of the video, but we go from the inside, outside in, inside out, in order to try to blend all those micro pouches and be able with suturing and getting rid of this superficial epithelium to really be able to blend the layers, okay? Which is almost impossible to create. And this is and this is all the suturing. This is how it looks like, and then we place the final crowns. We did 2 splinted final crowns. Today, I already extract this implant. I regraft everything, and I'm waiting how much bone is in there to decide what I'm going to do. Okay? But you see, dentistry is not an easy game. So this is Koso, who did the research, and he demonstrates that you have 83% of chances of removing all the epithelium if you do it outside. But if you do it inside, you have 86. So you have more chances to remove the epithelium inside the mouth than outside the mouth. Why is that? Well, first of all, is for me, I like to do it inside because I see the color change, and I have more control about how much tissue I'm taking out. How much should I take it out? Can vary from 200 microns to 600 microns. So if you take with only 1 millimeter of epithelium is more than enough. What is important to know that is when you have a really thin phenotypes, the problem is sometimes by the time that you take the epithelium off, you are just left with nothing. So if you do it in the mouth, you will always come up with bigger amounts of soft tissue. I want to show you something. I want to ask you, how do you do it? Do you cut first, or do you de-epithelialize first? And the question is really important. Every time you cut first, you have a problem. Why? Let me go back. Let me show it again. If you cut first, like he did here, and you go with the burr, the soft tissue, when you place the burr, where you have cut it, the soft tissue will do this. So you will always end up with pieces of epithelium on the line angles, on the corners, all over the place. So this tissue is full of epithelium. So you can use diamond burr, okay? But you can see this tissue is full of epithelium. Where is that epithelium? Just on the line angles, in the corners. That's why we never cut before. We de-epithelialize first, and then we cut afterwards. Okay? This is line angles. It's full of epithelium. So line angles are crucial. So I would like to show you how do you protect the palate. How do you do it? Do you suture first? Yes or not? Well, you have to suture first. Why? Because if you are pretending to place your collagen inside, the blood is gonna pull your collagen. So you first suture, and once you have sutured, you slide your collagen, which is much easier and faster. Do you use something to cover? I use periacryl, I use cyanoacrylate from the supermarket. Okay? And I will show you how we do it. So we first suture, then we place our collagen, then we place our cyanoacrylate, and then we polish our cyanoacrylate. I cannot show this on the periodontal meeting of the year because all the periodontists get crazy, but this is the reality. It works. Okay? They will tell you, no, because this cyanoacrylate is poisonous. So far, nobody has died yet from that. So I have a few questions to ask you, and I will show you a case where I failed, and I took soft tissue, okay? So I take the soft tissue, I have an idea how big the soft tissue will be. So first I cut with my burr without water, because if not the patient is choking. So no water, and you take your epithelium off, and then you cut your epithelium. In this way, your line angles will be free of particles of epithelium. Then you do, the more I do free gingival grafts on the buccal, the more I suture and go away from the free gingival margin. You need to remember that the thickest tissue is on the alveolar process, the closer to the tooth. So I place I glide, I elevate my suture and glide my collagen. And then what I do is you can de-epithelialize with laser. Those are the settings. 2.5 watts with 75 bulbs. 20% air and 40% water. Sorry. So you de-epithelialize, you suture, you put your collagen, and then you put your cyanoacrylate. You dry it. Usually, how you set the cyanoacrylate is with spray of water. Take a spray of water from the outside and you set it up. You dry it, you place another layer and another layer. Usually I place 3 layers. And I don't remove it after 2 weeks. Okay? Let me show you a video. Okay? So it will be clear in your mind. This is the way that I'm going to do a recession on an implant, on a central incisor, on a lateral incisor, and on a canine. Okay? So this is the way that I calculate how much I will need. the quantity of soft tissue goes from line angles to line angles, okay? And then we'll show you all the different steps, okay? So I need at least 3 millimeters of, this is how much I will need. So I go and de-epithelialize the soft tissue. It has only one bridge in there. I want to keep the tuberosity in the back. Then I cut inside what I have de-epithelialized and remove the whitest part. So I want to keep as much yellow that I see. What I want to remove is the whitish, the lamina propria. So this looks like this. Now the first thing I'm going to do is I'm going to suture. So I go distal mesial. I'm going to do some recessions. So I'm going to go distal mesial. And once I have suture, then I will glide. I have a cube. I squeeze it. I have a cube. And what I do is I blend it in two. Okay. I squeeze it and then I glide it below my suture, okay? Once everything is adapted, I dry it, and with the spatula, a Miller spatula, I go below the contact points and I throw spray of water. I dry it, spray of water, I dry it, spray of water. And what I want is to control that the liquid doesn't go to the throat, okay? So once everything is dried, I go with the burr and polish it so it's not as rough for the patient and it's comfortable. Okay? So this is the way that we have been using for the last 20 years. It works beautifully. The patient tells you, I don't feel anything, they can eat from day first. It's not a big problem. You can see that my hand doesn't, I can take as much as possible. I don't use any stent anymore. I use cyanoacrylate and it works beautifully. The second question I'm going to ask you is if I need another connective tissue graft and you have taken it from one side, where do you taken it again? From the same side or from the contrary? You take it from the same side. Why? Because the tissue will be thicker and denser, it will be more fibrous, and you will have more lamina propria the second time than the first time. So how much do I wait? Minimum 4 or 5 months. You can go back to the same side, exactly to the same side. Okay? Let me show you this case. Easy one. Lateral incisor, central incisor, class 2, huge class 2. So we're going to place extraction on number 12, place 2 implants and cantilever of the lateral incisor. Okay. So first we're going to do the socket preservation here, and we're going to do connective tissue graft on the central incisor to decrease the resorption, as I showed you before, because there is no bone. And then we'll do 3-unit bridge. So this is the situation. You can see huge class 2. So the first thing, see no bone, the buccal. You can see no bone on the buccal. little amount of bone. So here I show to the patient that I would love to, this is the provisional, I'm going to close the diastema, make a provisional from bone central incisor and to the lateral. And I told her, well, I would love to have a better soft tissue leveling, so I'm going to do the day of the extraction of the tooth and ridge preservation, socket preservation, we'll do connective tissue grafts on the teeth. Okay. But the connective tissue exploded. This is necrosis. This is because my flap was not, I pretend to place too much soft tissue in a small space. So now we have a problem, big problem, because now we have to wait. I'm going to reinforce, I'm going to take my laser or my electrosurgery. Please never pull. It stings like crazy. It looks like a dead cat on the mouth. So what you do is, you cannot cut with a blade because it goes all over the place. So the best is to have an electrosurgery to cut all the excess that is coming out from the pink area. You remove the provisional, you take all the yellow part which is necrosed, and then you resuture. You improve the antibiotics, we give metronidazole, and we see the patient every 4 days. Now the problem is, how much do I wait for the next connective tissue graft? At least 9 months. Why 9 months? Because this tissue is growing by secondary intention, and the quality of this tissue is really poor. So if you don't wait enough, you might have the same problem. So this is the day of that I saw the problem, 2 weeks after. Usually, I see all my surgeries 1 week after. Why is that? Because between the 4th and the 8th days is where you have the plasmatic healing. And I want to see that this is closed, that is not open. So in between 1 week, you are able to see if you have a problem or not. Okay? So usually if I have a problem, I take the provisional off. I take with electrosurgery or with a laser all the yellowish part. I resuture, I give antibiotics, I show the patient to use gels to maintain it as disinfected as possible, and I see the patient every 4 or 5 days. I resuture if necessary, until I get a situation where this is 3 months after. Okay? It's not bad, but I have lost a lot of verticality interproximally, volume-wise. Then I tell the patient now they have to wait 9 months. Yes, 9 months before I go back. So this is day 0 of the problem. This is 3 months. This is, I add a little bit of acrylic, and this is the Pontic 9 months after. Okay? And then I go back to the same place that I took the soft tissue from. Okay? So I took the soft tissue from this area when I did the ridge lab, which is just here. So I'm going to take it from the same side. Okay? Usually they say within 3 months you can go back, Usually I wait, in 9 months you have really good connective tissue back grafted. So this is my soft tissue, and I cut it in half and did a sushimi steak. The most important is that it's sutured with resorbable suture, and it's just perfectly fitting the papillas. Okay? And then what I want is to elevate the flap. There is no, everything is, there is a incision, circular incision, vertical incision, everything has been tunneled, and the connective tissue goes through the tunnel into place. Okay? I want to just suture it on the crest. Okay? Once it's sutured on the crest, as you can see here, sorry. When it's sutured on the crest, what I do is I reline my provisional. I don't want my provisional to be pushing the soft tissue. I want to maintain it just right there. So coming back to the process, day 0, I always see my patient between the 6th and the 8th day to see if I have any problem. If I like it, then the patient comes 15 days later from the surgery, take the stitches out, I check it again 1 month later, if everything looks great. And then at 3 months, I either take the final impression, or I need the second round of connective tissue to improve the volume. And again, I see every 6 to 8 days, 15 days, stitching out. Okay. So 15 days later, I cut the stitches off, and I take the shield that is protecting the wound. The wound looks like something like that. This is 15 days, but the patient is now not in pain anymore. She can chew on that area. It will be a little bit of awkward the first day, but after is a great situation. So here we place the 3.5 implants. As I mentioned this morning, you can see all the bone. Here we have is the proximal bone, and it's about 3 months later how the bone is just almost attached to the ZIL multi-unit abutments. You can see the extrusion of lateral incisor. So we remodel the soft tissue and make a veneer and splint it to the canine to finalize the case. So this is the trying of the mistake and the prep of the veneer. So we cut incisally, and then Yoshi sees the value and finish the case. You can see the papilla is in the right place, everything is leveled, and then we finish the case. This is cantilever of the 2 implants. Where we started, day 0 of the healing. This is 3 months, and this is the final work. So we have pontic, implant, 1 piece, and then a veneer on the lateral incisor. You can see the view from the top, where we started and where we finished. You can see the bone stability, the soft tissue problems we have. So you can see the stability of the veneer with the wire intracoronal. You can see here the wire has been bended and within the contour of the tooth. Okay? This is where we started. In each case, you can see the papilla height, volume on a huge class 2. Okay, so let me show you this case. It took me 3 rounds of connective tissue. He's a cardiac surgeon, heart surgeon, really famous in Paris. And his brother is a periodontist in Washington, D.C. And he said, if somebody can do this, you have to go and see Gaborena. So he's coming from Paris to have this surgery done. This is after 3 rounds of connective tissue grafts. But you can see everything you see in here is mucosa. So the soft tissue didn't keratinize the flap on top. Okay, so I have a problem. He's happy. I close all the spaces only with composite. This is composite here, composite here, composite here, composite here, composite here, composite here. No veneers, no nothing. And why the soft tissue of the overlying epithelium keratinizes is due to the elastin. This is really well described in this article. So this is my first connective tissue graft. This is what I was able to gain. This is my second connective tissue graft. This is my gain. And this is my third connective tissue graft. So this is what it looks like. He had aggressive periodontitis. This is, once I finish all the composites, how the tissue look like. This is 1 year after I finished. And then I say, please, allow me to do the free gingival graft. So I could have a better sealing of your soft tissue. So this is what it looks like with the iPhone video. And then he came back year after, and I did the strip technique from Han, and I will show you more cases about this. And 1 strip from the buccal, and 1 strip on the bottom, and then the tissue will take the information, and this is pretty much a year after, okay? Where we started from where we finished, okay? Not easy, but possible, okay? I used tuberosity also on big defects. You can see here another one. Looks like a bullet, highly blind. We did orthodontics, this is 2008. So I do a connective tissue during the orthodontics. I kept one of the teeth, I placed the implant, and every time you want to improve the papillas, you have always to graft on the adjacent teeth. Okay? So we need always an extension. You will see the implant depth, and then now we use a slim healing abutment. It's a temporary slim healing abutment. So it's basically, usually today I get rid of all this fatty tissue and make an incision. So the tissue is being sutured to the palatal. And then we make some extensions that will go over the adjacent teeth in order to improve the papilla, to diminish the recession of the adjacent teeth. So you can see those are really old videos to show how we manage not only the defects on the implant and the interproximal, but how we manage the flap on the adjacent teeth. Okay? So we cover with extra soft tissue the adjacent teeth in order to overcome the vertical defect. Okay? And then the flap will be no vertical releasing incisions and will be closed on top of everything. Okay? So you can see we're coming from the buccal aspect, getting into the flap, going back, and leveling the soft tissue where is necessary, and then covering above and below the prosthetic part of your healing abutment. We do the same for the central incisor. And then you will cover everything and suture it. Okay? So you can see the bigger amount of soft tissue is on the crest, and nobody can tell where is the incision. Okay? So this is 2 weeks after. Taking the stitches out. You can see how much volume we were able to reach and the case you have seen. Okay? So I will jump into these cases because they are really easy and show you more interdisciplinary situations. Is the tooth where we grafted, easy case, final result, having the same volume in both sides. So let me show you this case. It's a difficult case. It's a multi-unit, multidisciplinary approach, bringing the central incisor and the lateral incisor is a canine, and the first bicuspid is a canine. So every time you bring teeth forward, you need to reduce the diameter of the teeth. And this is something that the periodontist should be doing, okay? And this is a long case, difficult case. We wanted to bring midline, so you can see that we did a crown of the canine because it was huge, the reduction. We place these small healing abutments, and we'll go into that shortly. The incision is always buccal in order to improve the height and the thickness, okay? And use the implant to bring the premolar forward. This is how much the orthodontist was able to create. This is the implant, this is the canine, and this is the first bicuspid. So what I want is make a mock-up and see how much can I do. This is the situation here, and here is how much I want to bring the soft tissue down. On the root, I want to decrease the diameter of the canine into a lateral incisor. So we did a root canal in this case. You can see the root plasty that we did in order to have transform the canine into a lateral incisor before doing the connective tissue graft. Okay? And then we did the connective tissue graft, and we took full tubular density into the lateral incisor and to the premolar, which we want to have look like a canine. Okay? So you can see a lot of work that is done prosthetically and surgically to optically come up with a canine that looks like a lateral incisor and a premolar that looks like a canine with his contours. Okay? So this is on the top the aesthetic mock-up, and in the bottom what we were able to create surgically with connective tissue graft and reduction of the roots. Okay? So you can see the papillas now are very much leveled. It's a matter of changing the crown and finish the case. Okay? So you can see we did a veneer on the canine, the crown, on the lateral incisor. We modified a little bit the contours, and this is the finished case. Okay? What about keratinized mucosa? Usually this is a bridge, 5-unit bridge with 2 pontics. And these are the typical cases where you do connective tissue graft, you do a bridge, and you are full of mucosa. So the patient even tells you, well, this is moving. So usually I do free gingival grafts from the same color. I don't take free gingival grafts from the palate, especially if the patient shows it. Okay. And this is a pontic, is where she started and where we finished. The bridge goes from the lateral incisor to the canine. I'd like to show you another one. We place implants. This is a problem because I was stupid enough to keep the tooth between implants. But my idea, I wanted to keep this tooth because it's crucial to create my bone grafting and leveling the bone in this area. So if I would extract this tooth, I would have lost height and horizontality. Maybe I should have done a bridge instead of placing an implant, because if I place an implant here, then this tooth is going to move and it's a problem. Okay? So maybe I should have done a bridge. I did orthodontics, but on cases like this one where you don't have it's all mucosa, then you will have problems. Usually if the patient doesn't show, I will take the free gingival graft from the palate. Okay. This is the result. I don't care about the color because the patient won't show it. But if the patient shows the interface between the crown and the soft tissue, then I don't take the free gingival graft from the palate, I take it from the buccal aspect of the posterior teeth, and I will show you some cases. So this is the final case, and as I told you before, this doesn't come out of the blue. This is the try-in of the bisbake. My technician is here. This is COVID times, and I'm just telling him he needs to see what is in the mouth. And I'm telling him, hey, listen, you closed much my space. I want you to open it so the papilla will come down. I have grafted, don't worry. Leave it open, don't close it. Bring the tooth out more. I'm asking and telling him all the needs I see. I want you to create more pressure on the central incisor to center it. The value is okay. I love, you need to open the incisal embrasure. You open too much the canine here. Try to make it copy on the other side. try to level the papillas. And then the problem is that we have a natural tooth between implants. And say, Yoshi, we have a problem, you need to help me here. And what he does, he creates a hole. And I will show you different situations, different results. And here, what he does, he creates a hole. So we'll cement first the lateral incisor to have a perfect fit. And then we will screw retain the bridges, and we will use a wire which will be bonded to the adjacent teeth. So in this way, these tools will move. Okay? The contact points will be the same, and these tools will never have the chance to move. Okay? So this is what it looks clinically when we finish the case. Okay? When we started, I did the orthodontics myself. I did some internal bleaching here and finished the case. Okay? Let me show you the final result. You can see it doesn't show. Let me show you this one. This may be one of the most complex cases. This is Purin. Okay, he went to Barcelona. This guy is coming from south of Spain, from Valencia, actually Alicante, and they did a curry in Barcelona. And actually he has bone, but he doesn't have soft tissue, he doesn't have space, he has many problems. It took me 7 years to see what I'm going to do. Okay? So the first thing is that I have to center the midline because the midline is off by 1.5 tooth. So I want to center the midline in order to allocate the canine and the first bicuspid, which are missing on this area. So this is the second bicuspid, first molar, lateral incisor. First thing I'm going to do is I'm going to do a free gingival graft. Okay? Why? Because I'm going to move those teeth. And these teeth don't have any protection at all. So I will be losing more if I don't graft those teeth before the orthodontics. Okay? And what I pretend is to center the midline, like half a tooth or more, in order for me to, this is the situation, and I'm going to ask my orthodontist, in this case, one of the best orthodontists in Spain. Take your time. I have no rush at all. Take your time and move the first bicuspid into the second bicuspid into the first bicuspid. So what I want you to do is this. Okay? Once you have created the space distal, go slowly because the problem is that I don't have too much more on the mesial aspect. And moving these tooth in such a hard, dense bone, we will lose some resorption on the tooth. So take your time. I have no rush. Bring the tooth forward. Once the space is open, you send me a WhatsApp. And then if you have the same space, then I will place an implant here to just finalize the movement. Use this implant as an anchorage to bring the teeth forward and place another implant in the front of the first bicuspid. So this is what we do. It brings everything forward. I have the space to place an implant. Sinus is there. I have a short implant. You can see the little amount of bone after the second surgery. And now the problem is I did 3 gingival grafts, but now I have 1 implant in the front, 1 implant in the back, and a tooth in the middle. How do you solve it? Well, here what we did is a 3-unit bridge, and we place and make sure that this tooth is not touching the coping, just on the edges. I will show more cases like that tomorrow. So here you have single crown with a trough on the zirconia. So we will bond this trough. Here we didn't have space to make a hole on the zirconia. So if you see the tooth, here there was no space to make a hole. So what we did, instead of making a round, we make it divergent. Do a mechanical retention with my composite and have the wire inside. Okay. So this is one possibility. And then I have the coping and I do the bridge on top of my coping. So the coping really, what it does, it protects from decay. You can see the bone is coming back, and the root is holding the volume of tissue and bone. And this is a single crown on the posterior tooth. Can you take the note? So the final case, you can see here we have a crown of the lateral incisor. We have nice keratinized tissue. We have the second bicuspid is now first bicuspid, and then we have the implant in the back and the crown in the back. Okay. This is where we started. We did bleaching. So let me show you more difficult cases and how I treat them. Okay. This is my neighbor at the office. So it's a problem. Always treating your neighbor is always a problem. Okay. And we're gonna do a big bone graft, and she's wearing a removable. She's a young girl. She's on late 40s, and she has been wearing a removable partial denture all her life. So she's missing from T9 all the way up to second bicuspid. So you can see she has lost horizontal and vertical volume. She shows everything. So this is the idea. So I asked her, listen, we can place 4 implants here, a little bit of pink ceramics, and we are finished with it. No, I want no pink. I have seen some patients, I don't like it. And they say, well, the other option is quite difficult because we'll have to overcome all the loss with either bone and soft tissue, so it will take longer. I don't care, I want the best. Okay, so it's gonna be a long journey, I can guarantee you. So this is what we did on her. We placed 5 implants on the top. I did a Curie technique, but I didn't use patients on bone. These laminas here are from pigs. These lamina from a pig, lamina from a pig, lamina from a pig, pig. Okay? These laminas are 1 millimeter thick, and usually I have to wet it at least half an hour before I place it back. And then inside, what I use is 50% autogenous bone, 50% xenograft material. Okay. So let me show you the case. This is the video. I will go fast. Sorry. So we do always a buccal incision. I want to have an idea where the implants are going to go, and then I will make an incision buccal to where the implants are going to be. Why is that? Because it allows me to close and create verticality on the soft tissue. So I make it, the incision is really important to really be able to close it afterwards, because what I want is to create vertical and horizontal. So I open it, I deepitalize. I love this instrument, which is from MGK, that is triangled, and is the BW001. So I'm able to pull easy my flap and cover it. It has to go over my palatal. The stent has a hole on the palatal aspect, so I put my flap on that hole, so it's not, I place my stent and stabilize it and suture my palatal to the central post, which is holding the stent, and then I do my training, place my implants. This is the N1, the tiger, and place my implants, and then have an idea where the height based on the stent of the provisional restoration, how much bone and how deep those implants are going to be, and how much I'm going to upright my provisional. So not big deal. I do this lamina, cortical lamina. I adapted. I used piezo, and I fix those lamina that can be bent. Okay. And I position. This is carpentry. Then on the palatal aspect, I place where I want it. So it's much less morbidity for the patient, because this is coming from xenogenic material. Taking this amount of piece from the patient is, you can wedge the parts, you have all your time, you just scratch some bone from the rest of the mouth, okay, and then you fill it with 50% or 60% autogenous, 40% xenograft. You fill the spaces. You can use a membrane, it will be advisable. Here we use only LPRF. I should have used a membrane, a collagen membrane, and then an LPRF, and we close the wound. Okay. This is where we started. Sorry. This is 8 months later. How it looks. Be careful if you ever use this xenogenic cortical plate. Be aware that you need to use autogenous bone, so it doesn't become a sequestrum. Okay, and you need to integrate as much as possible with autogenous bone, with patient's own blood into patient's body, okay? And stability of the auspices, as you all know, is mandatory, it's crucial. So we have a great blend. I should have used some sort of a higher healing abutment in order to bring the bone more crystalline, and is what we do today. And in this case, we place some multi-unit, Z multi-unit abutments with 70 degrees and 2.5 millimeter. The problem of grafting crystally around such a big healing abutment is difficult. We do it totally different now, and I will show you some cases maybe tomorrow or later on if I have time. But trying to really be able to graft on the crust is really difficult with such a big healing abutment. It's possible, but it's difficult. The idea here is to have the narrower healing abutment, and there are some ideas I will be able to share with you to really able to create that. So today with the slim concept that we came out with, we use guided pins, which are just for guiding the position of the implants. We use these as a healing abutment rather than this. So here I can graft crystally with a rod that is 2 millimeters. And I will show you some examples later on where you can graft and create and perform really high aesthetic results. Okay? I'm a periodontist, and the way that I was taught is that after this I need to increase the keratinized mucosa. And should I do it before or after the provisional? So for me, the best is to put the provisional first, because now as a surgeon I have an idea how much keratinized mucosa I need to graft. You can see the mucosa line, the mucogingival line. You can see that we have a problem, especially aesthetically. The patient can tell you, wow, yeah, I like it, but what about this moving thing here? Can you get rid of it? Yes, we'll have to do a surgery. But the amount of surgery we have to do is huge because I don't have enough tissue to graft from. Okay? So the problem is going to be the color, because the patient is showing everything. So how to increase the keratinized mucosa? You have 3 ways. You can do a free gingival graft, but here the patient is showing it. It's like taking it from the palate or rotate the palate. I will have the rugae on the buccal area, which is rather ugly. I can have the strip technique, autograft, or the apically reposition, but I cannot apically reposition because I don't have any keratinized mucosa to start with. So if we take the provisional off, you can see that there is little or non-existent keratinized tissue, just here, a little bit here, this old mucosa due to the buccal incision, of course, but really for the manipulation of the flap. Okay? So what I did is the hand taquet strip technique, which is sutured. The buccal strip is taken from the buccal aspect and is sutured the most incisal part. Then you create a bed. The most important is to suture the lip where you think the vestibule will go. And then the palatal strip, you're better off make strips that are wider, at least for me today is 3 millimeter in thickness. And I want to show you what happened. So I suture, and those are the strips from the palate. And you can see here the strips from the buccal aspect, both sides, that were sutured. This technique was popularized by Yves Van Urban because he came up with the idea that you should place like a xenogenic collagen matrix in between the bottom and the top graft. But for me, I think it doesn't make any sense at all. You get the information, the genetic information from top and bottom, and you get the soft tissue. Okay? So we have now, I use Derma from Osteogenos. It's easy to suture, much better than the one from Bios. But I want to show you what happened. Okay? The most important of this technique, having a provisional restoration as a surgeon, it gives you a better idea how much gingiva you need. I was planning to have 6 millimeters. And you're gonna see what happened. This is just 2 weeks compared to 3 months. And the tissue grew back. Why is that? Well, I was not careful enough to suture my lip into the position. So the most important is to suture the lip exactly where you want it, because if not, you will go back to the same position. So now I have a problem because the patient went through one surgery, and then I was not able to reach what I wanted. So I told her, listen, when I placed the final zirconia bridge, I love these bridges from Nobel, and what we did was a full contour bridge. You can compensate up to 25 degrees. We push the tissue, and these are the Omni grip screws, and this is my reality. I still have more keratinized mucosa than before, but it's not what I was planning. So Yoshi finalizes bone-wise, everything looks beautiful. We are really happy with the connection. This is the reality of what I have in the mouth. So I'm planning to place the final zirconia abutment, so the soft tissue will heal better against the zirconia than with my provisional acrylic bridge. So you can see the situation. It's very nice, but it's not optimal. So I don't do dentistry for my patients, I do dentistry for myself. Okay? So I place and I push the tissue with the final zirconia abutment. And then I decided to, this is the day 0, how it looks like. Of course, this tissue will come down. This is how it looks like with the provisional. This is how the tissue crept back. But what I'm going to do is I'm going to reposition apically my soft tissue. So what I did is I cut part of my mucogingival line. Here is the tricky area. And now this time I'm going to suture really well against the periosteum of the buccal to really level the soft tissue And this time I will bevel the soft tissue so I don't have a step. We use laser. As you all know, epithelium grows 1 millimeter every 2 days. And it's amazing how the tissue grows by itself. I bevel it. This is excuse me, the video of the de-epithelialization and the position of the flap. You can see part of the flap, and the repositioning has the same color of the soft tissue here, so everything has the same epithelium, and then tissue will grow in between. This is just 2 weeks after. You can see here how it looks, the different stages and the difficulties we have been encountering just to get to 4-5 millimeters of free gingival of keratinized mucosa. So you can see 4.5 normal scallop. We have implant, montic, implant, implant, montic, implant, implant, and you can see how much tissue is pressured. As soon as you take everything out, how the tissue rebounds, where we started, how we finish. We did the veneer on these tools and this molar and the crown. Sideways, we did bleaching in the bottom. We did some bridges on the posterior, lower and lower posterior. We opened the bite and the final work. Coming back, just 1 second, one remark. Usually, if I have one molar and I have loss of buccal, bone volume, and height, I prefer to do a bridge than 2 implants. Because if not, it's difficult to catch up the same volume loss even with bone graft and soft tissue graft. I prefer to do a 3-unit bridge. Patient is more comfortable. We make narrower pontics. It works really nice. This sideways. This is the iPhone videos from different stages. This is 1 year and a half. This is the smile with the removable partial denture and with the fixed bridge. With the Nacera crown with N1s and the Z attachments, where we finish it up. Okay. Good. So we are done for this afternoon. Tomorrow, more and more difficult. I know that you have a lot of cleft palate patients, and I will show you some cases that you have never seen before and how difficult dentistry can be. Okay? So if you have any question, maybe we can keep it for tomorrow. Please write it down. I'm rather tired, and tomorrow more and more intense, and we look at more difficult cases. Thank you very much.